welcome to Preemie Chats. Preemie Chats is a program that is for healthcare professionals and parents to talk about what matters most to you, to explore new ideas, and to learn together. I'm Leah Whitehead. I'm mom of a preemie and former journalist, and I'm happy to be your host today from Halifax, Nova Scotia. Preemie Chats was created and is put on by the Canadian Premature Babies Foundation, which is also well known as CPBF. The foundation is a parent-led charitable organization that helps families in and after NICU through education, support, and advocacy. If you have a heart for preemies, whether you're healthcare professionals or families, then please check out CPBF's website. It's there on the screen, CanadianPreemies.org. There you will find resources, the latest projects, and most importantly, a community of people who want to see our little ones thrive. Today's session is live, so please bring your voice to the table. We love to hear where people are watching from, and we love to get your questions, and we try to get to those at some point during our program. It is through rich conversations like these that we can advance, practice, and learn together. So please participate and let us know where you're watching from. After a stay in NICU, families can be a little nervous taking their little ones home, especially this time of year, because we know there are a lot of bugs going around. So is there anything we can do to prepare to prevent infections? We're going to hear some strategies today as we focus on what infectious diseases are expected to circulate in the coming 2023-2024 respiratory season, and talk about how we can prevent them from circulating in our homes. Leading the conversation today, we're going to be joined by Dr. Joanne Langley. Dr. Langley is a pediatric infectious disease physician and vaccine researcher at the Canadian Centre for Vaccinology at Dalhousie University. She's an active investigator in the Canadian Immunization Research Network and is the co-lead of its clinical trials network. Dr. Langley's work also focuses on vaccine policy and evidence-based decision-making in immunization programs. During the COVID-19 pandemic, she has been serving as the co-chair of Canada's COVID-19 Vaccine Task Force and as a member of the COVID-19 Science Expert Panel for the Chief Science Advisor of Canada. She is a former member of the Canadian Task Force on Preventive Healthcare and Canada's National Advisory Committee on Immunization. So this is someone who knows her infectious diseases. So Joanne, thank you so much for joining us here today.
My pleasure, my pleasure. I'm very happy to be there with all these parents and their young babies.
I'm going to put your presentation up and let you get right to it because you have lots to share today.
Thank you, Leah. I thought I'd start with a few slides just to provide some background, so we're kind of thinking along the same foundational information, and then happy to answer any questions at all after that. So I work at Dalhousie, and I'm at the same institution that Leah is, actually the IWK, here in Halifax, and I work at the Centre for Vaccinology. So I always would include disclosures in my talks. The first paragraph is volunteer work that I do. I don't get paid for any of that. And then the second group, research grants, I don't personally get paid. The money goes to my employer, which is Dalhousie University, and that's used to run our clinical trials. And we have a big focus on trying to prevent respiratory infections, flu, pertussis, RSV, and so on. So this is of great interest to us. So I thought I'd step back and kind of look at the world. How big a problem are these respiratory infections? And actually, even now, 2023, so this is something called the Global Burden of Disease Study that has been done periodically for at least a decade. The most recent full one was in 2021. And even though we have so many vaccine preventable diseases and we know so much about preventing infectious disease, half of deaths are due to infectious diseases still. Pneumonia or lower respiratory tract infection is another term that's used, or LRTI, accounts for 13%. So you'll see in this square would represent the under 5-year-olds. Not really a square, is it? It's kind of an oblong. So the big orange block here is neonatal deaths. So those are deaths in the first 28 days of life. And these are not so much in North America. They're in places where they don't have the ability to recognize neonatal problems early and get medical interventions quickly. But lower respiratory tract infections in the paler orange here on the right is a big cause, with tuberculosis being a big part of that. Then diarrhea, again, these are going to be infectious causes, human immunodeficiency virus, sexually transmitted infections, malaria, measles. So we still have a big obstacle in front of us before we can really protect the world's children. Now, most respiratory infections are spread by large droplets. There are exceptions, but let's just talk about the most common route. So in the course of sneezing, talking sometimes, coughing certainly, we generate these tiny droplets that are not visible to the naked eye, really. They're over 10 microns, so like a cell would be in the micron range. So we don't see them generally, but they go 3 to 6 feet, that is 1 to 2 meters from the sneeze. So anything in that radius, the droplets can land there. If you're a person in the way, they can land on your eyes, your nose, your mouth, and you could be infected by that route. If they land on a surface and you touch that surface and then, rub your eye because it's itchy, you could get infection that way. Now, exceptions to these large droplets are airborne infections, and there aren't too many of those, but they're important ones. Tuberculosis, chickenpox, measles are almost always spread by the airborne route, and these particles are even more small, and they can actually stay suspended in the air and go to the next room, and people inhale them. Then they land in your lungs, and that's how they start their path to infect you. We can also, in the healthcare setting, generate these teeny-weeny particles that become airborne. So, for example, when we ventilate someone, when we do intubation to get a procedure done, like getting a sample from the lower respiratory tract, we can, in the course of that medical instrumentation, generate these small particles. So then we move to a different level of protection where we have airborne exchange in the room, so more frequent exchanges. You would see healthcare workers wearing an N95 as opposed to a surgical mask, having eye protection, and so on. So from an infection control perspective, this is kind of the mechanisms for how infections are caused. And I think this is important because we can act on this evidence. So you see up in the top left here, direct. So that's when you directly touch another person, and that's how you acquire the particle. So handshaking is a way of doing that, but this is also the category for sexually transmitted disease because the two hosts are together. So that's why washing your hands makes sense. Indirect is, you can see there's an object in the air. That's when you touch something. So a child sneezes on a toy, another child comes up and then starts slobbering all over it. Then droplet are these large particles that I was just telling you about that come from can land on our conjunctiva. That's the eye, the mouth, and the nasal passages. And then the second level is non-contact, so airborne, vehicle. So that's, if we use a needle, put it through into something, contaminate the bottle, and then go back into that bottle. And then vector-borne, so malaria, for example, is spread by mosquitoes. We do have lots of human defenses against infection. We're just made to ward off infection. But if you're a very premature neonate, or you're immunocompromised, or you have underlying lung disease and can't cough, for example, these defenses may not be as strong for you. So we have human behavior, we have knowledge about how to prevent. And for newborns, that's their parents and their healthcare providers preventing them. We have physical defenses like cough, sneeze. Having intact skin will prevent infections that get in through our skin. Then we have our immune system, and we have a non-specific kind of immune system that acts right away and charges in to prevent infection. And then we have the adaptive immune system. And that's the part of the immune system that once it encounters an antigen, whether it's a wild infection like being exposed to it or a vaccine, will then process it in a way that we have remembrance. We can remember that the next time we encounter it. And when we think about risk for infection, we think about the host. So what are the factors that make the host strong or not as strong? The infectious agent and the environment. So our environment can affect this as well. If there's secondhand smoke in the environment, that increases risk. If there's wood burning stove, then there's these tiny particulate matter in the environment, and that can increase risk of airborne infections. Then there's the children themselves. Kids have their own behaviors, and they're going through developmental stages through early life, and they can put themselves at risk, whether they're, in contact with animals in direct contact, or they're, in childcare settings where they have close exchange, or this little fellow up on the top right who's got a vent, mechanical ventilation and can't cough normally, and has this plastic device in his airway, and his health caregivers have to interact so closely with him to take care of him that there's increased risk of transmission that way. We're facing the winter. We know the winter in a temperate climate, so most of North America, we have these annual outbreaks. And here's an example of the top one is just that when researchers recognized there were regular outbreaks every winter, and then we discovered RSV virus and found out that 60 to 80% of the outbreaks are due to RSV. So RSV is the biggest player that we may know about, but there are a lot of different viruses, and some of them are vaccine preventable. I mentioned vaccines just to show here, this is the what we think happens to our immune system. So here we are at the point of time on the bottom left, where we haven't been exposed to an antigen. When we get exposed the first time, we develop an immune response, but it's going to take a couple of weeks to kick in. And then it will settle to some extent, but we will have this memory. But the second time that we're exposed to the pathogen, our response is much stronger. So the secondary response is much stronger, generally speaking, the second time you're exposed. Here are some of the vaccines that we can get to prevent infection. I show you this first slide before I actually got the information, because you can go into the Government of Canada website, implement your province and the age of your child, and it will produce an immunization schedule for you. So I pretended here that I had a child who was 6 months and that I was in Ontario. And this is what it told me, that at 2, 4, and 6 months of age, I should get this series of vaccines, and then another set at 12 months and 18 months. Now, many of these vaccines prevent respiratory infections, and those include diphtheria, which can cause heart disease and airway disease, tetanus, which is a disease that causes muscle spasms that prevent the child from breathing. So they go in these spasms and they can't actually inhale and exhale. Pertussis, which is whooping cough. Polio is interestingly can be considered a respiratory disease because you damage the nerves that go to all the muscles in your body. And that includes the muscles that cause you to breathe. Haemophilus influenza type B causes meningitis and pneumonia. Pneumococcus obviously causes pneumonia. Rotavirus doesn't cause respiratory disease. Here you're getting boosters and at 4 and 6 months. And then at a year, you get protection against measles, which causes pneumonia. And then those are the main respiratory infections. Now, every year you can get influenza vaccine. And for babies don't get their first influenza vaccine until they're 6 months of age. Not on this particular slide is the COVID-19 vaccine, and that is available for babies starting at 6 months of age. And I understand that last week you had a session on RSV, so you would have discussed the monoclonal antibodies that are available to prevent that. One tool you can look at in your community is to know what viruses are circulating in your community. And the Public Health Agency of Canada, sometimes called FAC, has a weekly respiratory virus detection report. So you can see the last week they reported for was October 21st. And they're telling us that there is an increase in SARS-CoV-2. Enterovirus, rhinovirus is decreasing. So that's a virus that tends to occur late summer, early fall. It causes upper respiratory tract infection for the most part. And so this is what the slides and the tables and figures that you will find on that website look like. So this is available to you whether you're in the public or a healthcare provider. So we look at the same information as everybody else does as a healthcare provider. So you're looking at the number of tests that were done and how many were positive. So here's COVID, and you can see that about 20% of tests are positive. Influenza is just starting. We're here. No big outbreak of influenza, and RSV has not had its annual outbreak yet. And here's some other ones that we watch that cause respiratory infections. Enterovirus. So here on the far right is where we are right now at week 31. And it's kind of decreasing or settling. Human parainfluenza, adenovirus, metapneumovirus, and coronavirus. And you can also search all those viruses on the website and it'll give you some information. This is influenza and where we are in the year. So we haven't yet had our outbreak. There's time to get all the vaccines that we need. Now, one way besides immunizing your child is to immunize during pregnancy. And we currently recommend vaccinating women for influenza, pertussis, COVID-19, and tetanus, but not for varicella. And here's some resources for about vaccines and about a whole slot of information about those diseases we talked about that's on the Canadian Pediatric Society website. So I'd be happy to talk about any of that or anything different and preparing for this winter season.
Thank you so much for sharing that with us. I'm going to leave that last slide up for just a second because those websites are helpful for people to take down. And we do have a comment here from Farah. And she said, "My name is Farah. I'm an ex-Preemie, and I'm always interested to see how interventions and tools have advanced from 1980 when she was born to now." And so I thought, it's an interesting comment of what do we know now that perhaps we didn't know? Has our knowledge been advancing in this area very much in the past 40 years?
Super question. Yeah, and I'm interested in this as well because, sometimes even the trainees we have, they don't realize what life was like 20, 30 years ago and how much better off we are now. So there's a lot of new vaccines that have been developed to prevent a number of infections. So back in the 1980s, we hadn't started using pneumococcal vaccine. So PCV13 is what children get now. There will be PCV20. The advice for children will be coming out in this calendar year about this newly available expanded valency vaccine. Pneumococcus, Haemophilus influenza, those were all newish vaccines. I would say another thing that we didn't understand as well back then was the microbiome. And the importance of recognizing that we are all colonized. So we have a layer of bacteria and viruses in our mouth, around our eyes, in our upper respiratory tract, over our skin, in our gut. And they're not inert. They're actually important for our own health. They play a role in the development of the child, in prevention against allergy, in developing the gut, and protecting us against many infections. We really need them. And so we are much more careful, I think, about how, as healthcare providers, whenever we think about prescribing an antibiotic, to think, do we really need this antibiotic? Because prolonged use of antibiotics will disrupt the patient's microbiome, that lovely layer of bacteria and viruses, and may allow bacteria and viruses that are resistant to antibiotics to emerge, or ones that aren't as beneficial. So we're much more careful weighing those kinds of decisions now. And there's so much research going on now trying to understand how to promote the microbiome. We talk about, well, can we take probiotics? Well, not all the probiotics that are on the shelf are really useful. They're all a little bit different. They contain different things. Some have actual live bacteria in them, some don't. So that the science of and promoting the microbiome is also in development.
I know too, just in conversations in NICU, when we talk about skin to skin with mom in the first, couple hours of that, the concern way back when used to be that bacteria that they could get from their parent. And now it's even that thought of, it's actually a very good thing for that transfer.
Exactly. That's a wonderful example, that one-on-one contact, because we want baby to have mom's bacteria, and on the way out, that's their first exposure. But skin to skin will allow them with mother-father contact, breastfeeding, all those things give the baby a great start to a good, healthy microbiome.
I have a few questions here just based on your presentation. One of them, you said in passing almost, but it flagged for me, was about smoking, an environment where there's smoking or where there's wood stoves, and how that increases the risk of airborne infections. And I'm just wondering, do we know why that is? Is it because it depletes your immune system, or does it have something to do with the actual airborne element of it?
Yeah. So this is best known for cigarette smoking. And in that case, if you're in an environment where someone is smoking, so you're a secondhand smoke recipient, the exhalation and the cigarette smoke, it's, we see that visual smoke. It actually has in it little particles that land on the airways of people who are around the smoker. And they, just like cigarette smoke is damage to our own lungs if we're a smoker, they can be damaging to secondhand smoke recipients. And this is why, smoking is banned in restaurants and closed spaces. It's a public health measure to protect people who aren't the smoker. So there's that harmful element that impairs our own defenses, which are there to prevent the bacteria or the viruses from making their way. I didn't, go through all how detailed our respiratory tracts are, but we have this layer of mucus. We have something called a mucociliary escalator. And so each respiratory cell has a little hair on it called a cilia. So we have thousands of these little cilia that are moving along the mucus to be coughed out or swallowed. And so every bacteria or virus that lands on there that isn't supposed to be there, it's constantly being escalated out of our respiratory tract system. But if we damage those cells, then we don't have that defense working 100% for us.
It's very interesting. And I think of that too, and maybe this is it, and I'm just making this connection, is people always talk about breathing through your nose because you have the little hairs in your nose that do kind of act as that protective layer as opposed to breathing through our mouths.
Yes, the nose plays an important role. It humidifies the air that's breathed in, and it brings it to a body temperature as well. So it warms it, humidifies it, and as you said, there are extra particles that are not necessarily in the mouth, that respiratory epithelium.
You had mentioned a couple websites where people can go to see what is circulating kind of real time, which is super interesting, I think, just to know. But is it helpful for people? Are there different things, I guess, we can do based on what's circulating? Or is it just good for us to know what our babies or kids might have?
Yeah, so there's a lot of information, and you don't need to look at those graphs to protect your child, but some people are interested in digging into it. I think that the key thing is that when you're in RSV season or flu season is upon us, and you will probably get that message from public health through other channels, Instagram and so on. I think it's wise not to be taking babies, especially in those first few months of life, into crowded situations. Because that's when you're going to, if the baby gets sick in those first few months, those are the times when the children are at highest risk for the more complicated RSV and flu. So that would be one of the main things. And then to try and get your vaccines before the winter season onset. But otherwise, knowing what exactly is going on at any one time is, I agree, not super helpful. And you don't want to be worried about something that you can't necessarily prevent. But in general, I think it's a good idea if there's people that are sick in your family or your contacts, maybe it's not the best time to visit with your newborn child.
I think that is great advice. And in fact, I always tell families who I meet in NICU that when I took my preemie home, I would ask people, "Are you feeling well?" And I realized I had to adjust that question because people would say, "Oh, yeah, I feel great." And then they'd come over and either cough or sneeze, and it's like, "Oh, no, I didn't." Like, you might be feeling well, but if stuff's coming out, then I didn't want them in our environment.
Yeah. Very good. Yeah.
I just wanted to address as well, we're coming out of this restrictive COVID-19 era, I guess. There is more freedom with whether people choose to wear masks or not, and just things are relaxing a little bit in that regard. But is there a balance in terms of with our little ones who are maybe in daycare where we know, lots of things are coming home? Is certain exposure good for the kids when they're around a bunch of children? Or again, is this something that we should be safeguarding against?
Right. So it really depends on the child, I think. If you have a high risk child, so, very severe lung disease. And that's going to be a different situation than a perfectly healthy child. Kids do need to be exposed to infections as they go through their early years. And when you compare children at age 6 who were either raised at home and never went to daycare, or were in a daycare, compared to children who were a small group, like 5, kind of out-of-home childcare setting, the total number of infections by age 5 or 6 is about the same. It's just when they get them. We do recognize that infections are part of our exposure, and some of them are going to be pretty benign. So not to be fearful about those, but you are more vulnerable earlier in life, especially those first 6 months. So that would be the period I would think, especially if you have a child who might be a little more higher risk, to try and use all those protective measures.
Mm-hmm. You had alluded to this before about being careful, I guess, not to be afraid at what might be out there and what may impact our little ones. And often, a concern that's raised as families are leaving NICU is they're in such a contained environment of, everyone's washing their hands. Visitors are limited. Baby is almost in this little safe bubble. And then you take them out into the world. And do you have any advice for families on how to balance that, the reality of that you have to be careful, but also not wanting to delve too deeply into the fear of what could happen?
Right. That's really important. So if you're still have a baby in the NICU, I would talk about that with your healthcare providers. It does depend on what time of year you're going home. If you're going home in the summer, you're in a pretty good situation. You're going to be outside a lot. The risks are lower. So it's not forever. It's a couple of months. And I think, to be reasonable and avoiding people who are clearly sick, particularly that first, the neonatal period, even if you have a healthy baby, who's not premature, that first month is still risky. They're still not fully strong from an immunological point of view.
Mm-hmm.
So I would talk about it with your nurse, your healthcare provider, to get a balance of, we're going into the world, it's going to be great. There are going to be some infections, but to start, I'm going to make sure I'm not exposed to people who are clearly sick. And if I'm sick with a respiratory infection, well, first of all, I'm going to make sure my household family gets all the vaccines they need, so I'm not bringing infections into the house. And if I'm sick, I might wear a mask, get people to, during that period, because parents have to hold the baby and take care of them. But then, in a few months, it's just going to be life, and infections will happen. So it's not forever. It's that initial period when you're making the transition from this very protective environment to the outside world. And babies are growing all the time once they're out, and they get stronger as they do that.
I love that advice, that it's a temporary space, a span of time where people have to be a little more careful. Now, in terms of what's infectious and what's categorized as infectious, we hear all kinds of things as members of the public in terms of saying, like, you're infectious before you even see any symptoms of any of these things. And once you are displaying symptoms, it's not as bad unless you're actively coughing or sneezing. Is this right information? Or it's kind of like there's so much info out there about infections and viruses, and that it's hard for parents to keep it all straight.
Yes. So we say that during the period when you have symptoms, you're almost always infectious. And we can't really tell the difference between what virus you have. So it's best to treat a person who's got symptoms as potentially being infective. Now, some infections have a period before the onset of symptoms where you can transmit infection. It's not every virus or bacteria, but it's true for flu. It's true for chickenpox. It's true for COVID. But it's not true for every single virus. So it doesn't help us a lot for flu because the time period between symptoms and transmission is so short that you can't really intervene. It's just too short a time. So that's why during the pandemic, it was useful to know about people shedding and backtracking to figure out who they'd been exposed to, certainly in the hospital setting. But for many viruses, we can't act on that knowledge very well just because transmission happens so close to the time when you would have that pre-symptomatic period. Yeah. So it's not every virus. And certainly if someone has symptoms, you can safely assume they're likely to be coughing and spitting out bacteria or viruses.
You can understand the confusion, but it makes sense that not all viruses act the same, for sure. I'm going to just wrap up our time together, but wanted to ask if, first of all, if there's anything you wanted to add that I haven't asked you about in terms of prepping or preventing any of these infectious diseases coming into this season.
Well, I would probably end by saying we don't know for sure what this winter will look like. Parents will be aware that last year was an unusual year because we'd had the society-wide public health measures in place for almost 3 years. And during that period when COVID was circulating, infections in children plummeted. So they were mostly absent for many, many infectious diseases. Certainly for flu, RSV, they disappeared. Then we had an unusual season last year when influenza and RSV came earlier than expected, so out of season. And all the children that didn't get infected when they were in their first year of life during the pandemic got infected, as well as children in their second year.
Right.
So we had a lot more cases last year. So now it's the year after that. We're not exactly sure if we'll completely go back to normal, where RSV starts and flu start in the fall, peak over the winter, and then go away. Maybe they'll come a little early. Maybe they'll come a little late. We don't know for sure. So the surveillance systems are in place to help us figure that out because, they determine how we set the date for palivizumab, for example, use in a province, but also for planning for when there'll be a surge in people coming to emerge. So this year, we're not exactly sure. We can't really predict what is going to happen as to when the outbreak will occur.
It is an interesting time in history because, like you said, it was, I know for our household, it was the healthiest we'd ever been during COVID because everyone was washing their hands and limiting exposure. And you could definitely see the advantages of, the wider community doing something as simple as washing their hands, what kind of difference that made to our health.
Exactly. It was a real learning about what we can do as a society when we really have to.
Right.
Yeah.
Well, thank you so much for joining us and for sharing your knowledge and for just helping us feel a little more comforted as we come into this season of germs. And I know that you're probably entering your busy time of year, but I appreciate you taking the time to join us today.
Thank you so much, Leah, and thank you for inviting me.
And thank you, everyone, for joining us today for this edition of Preemie Chats. I just want to give a special thank you to our sponsor, AstraZeneca, for their ongoing support of our educational program. And if you missed any part of today's edition, you can head over again to canadianpreemies.org. On that website, you will find this full episode, as well as any past episodes that you may want to rewatch or watch. And you'll find many resources and support options available there for you. And you'll also be reminded that CPBF is a charitable organization, and it depends on support to continue its important work. Consider how you can support CPBF in its mission to empower families of premature babies in every step of their journey. Together, we can create a brighter future for all preemies and their families. I hope that you're able to join us here next Friday at 1 p.m. Eastern Time as we continue the important conversation with a specific focus on RSV. So not only will we be talking about how to prevent it, but we'll also be discussing a national survey that CPBF performed on parental knowledge and understanding of RSV. And we'll be sharing those results, so you won't want to miss it. I hope you're able to join us, and hope everyone has